The occiput anterior presentation is the most efficient way for a normally proportioned fetus to pass through a gynecoid pelvis and occurs in around 85% of all vaginal deliveries. In an occiput anterior presentation, the lie is longitudinal, with a cephalic presentation. The attitude is flexed. The determining point is the occiput. The eccentric pole is the occiput. The point of rotation around the pubic symphysis is the posterior hairline. The diameters of the head descending through the pelvis are the suboccipitofrontal, 10 cm diameter, and the biparietal, 9.5 cm diameter. For a more detailed elaboration on the definitions used in labour, refer to the course Mechanisms of Labour. At the start of labour, the fetal head has usually already started engagement in the maternal pelvis. The presenting part is at the upper edge of the maternal symphysis pubis, which is also known as Hodge 1. As the fetal head engages and descends towards the pelvic brim, it is in the left or right occipito-anterior position. This is so the widest part of the head fits through the widest available part of the pelvic inlet. The head will pass over the promontory of the pelvis, and the skull will be in a posterior asynclitic position. This means that upon vaginal examination, the sagittal suture is anterior to the pelvic axis, and since the fetal head is minimally flexed, the posterior fontanelle is felt in the left or right anterior plane of the pelvis. Descent takes place throughout the whole second stage of labour. At Hodge 2, the occiput is at the lower edge of the symphysis pubis and about 1/3 of the way towards the pelvic outlet. The fetal head has passed the promontory halfway and will reach a synclitic position. Due to the resistance that the head encounters from the cervix, the walls of the pelvis and eventually the pelvic floor, the fetal head flexes so that the chin is touching the fetal chest. During a vaginal examination, the sagittal suture will be felt in the pelvic axis, and the posterior fontanelle will be positioned closer to the pelvic axis. Further descent takes place until the fetal head reaches Hodge 3. Due to further descent, flexion increases, creating a smaller structure to pass through the maternal pelvis. At Hodge 3, the presenting diameter is suboccipitofrontalis. The posterior fontanelle comes to lie closer to the pelvic axis. The eccentric pole develops since there is a part of the presenting part that lies outside the pelvic axis and lies deeper than the part that lies inside the pelvic axis, as seen here. The head has now passed the promontory completely, resulting in an anterior asynclitism of the fetal head. During a vaginal examination, the sagittal suture will be felt posterior of the pelvic axis. The posterior fontanelle has come to lie closer to the pelvic axis. When the head reaches Hodge 4, the presenting part is at the pelvic outlet. With descent progressing towards Hodge 4, internal rotation occurs, in which the occiput rotates to an occiput anterior position when reaching the pelvic outlet. When the head is at Hodge 4, the posterior fontanelle is felt anteriorly. After internal rotation of the head, further descent occurs until the occiput lies underneath the pubic arch. Flexion decreases due to the forward bending curve in the birth canal. With each contraction, the skull pushes against the pelvic floor. The back of the head finally becomes visible in the vulva during a contraction and will retract again between contractions. When the head no longer retreats in between contractions, it stays at the pelvic outlet, as seen here, which is also known as crowning. Next, delivery of the presenting part, which in this case is the occiput, takes place by gradual extension. The head deflexes and is borne by rotation around the symphysis pubis. The pivot point is the nape of the neck. Then, internal rotation of the shoulders takes place to be able to pass the pelvic outlet. This can be seen outside by an external rotation of the head around the long axis of its dorsum. The head is grasped by the healthcare professional's hands and subsequently bent in sacral direction to deliver the anterior shoulder. Subsequently, the head is bent in ventral direction to deliver the posterior shoulder. The remainder of the body is borne by lateral flexion as the spine bends sideways through the curved birth canal.